it makes me think patient care is like Albania. You can't really understand it by reading about it. You have to go there. So we have as our first speaker someone who has gone there in patient-centered care. Dr. Mary Walsh chairs our ACC Patient-Centered Care Committee. She's going to talk to us on the evolution of patient-centered care and its relation to cardiovascular outcomes. Minnow.
Thank you, Henry. I don't think I can follow that joke. Welcome to all of you. I really appreciate all of you coming and your interest in this particular topic. Henry kind of stole my thunder because I was going to ask you to raise your hand if before today you understood what patient-centered care meant. Raise your hand if you fully understand what that means and why people are using it. Okay, good. So I became chair of this committee because the year of the patient, I went for a run with Dr. Fred Beauvais, the president. Watch out who you run with. He said, I got this great idea and here's what we should do. So we're not going to talk specifically about the committee's work, although I'm happy to fill you in on that later. What I want to do is kind of give you a primer on patient-centered care so that you come out of here this morning understanding at least kind of where this term came from, why people are talking about it, and some of the values that we think we see with patient-centered care. So, excuse me. Why patient-centeredness? This is the hue and cry from the patient community, and I want you to keep this in mind throughout today. Nothing about me without me, and that's accredited to Valerie Billingham. What is patient-centeredness? The term was actually first coined by a British psychoanalyst in 1969, and she described a form of psychotherapy that general practitioners could provide for patients who had illnesses that were partially or wholly psychosomatic. This contrasted for the first time with illness-based care, so patient-centered versus illness-centered. More recently, in 1988, the Picker Institute coined the term patient-centered care to address the needs of clinician staff and healthcare system to focus care, again, away from the disease or the illness and toward the patient, him or herself. So the Picker Institute at that time, and again, that was 25 years ago now, identified 8 characteristics of care that are the most important indicators for quality and safety. Those include respect for the patient's values and preferences. This is a cornerstone of patient-centered care. We don't just think about the disease, we think about the person with the disease and what his or her values are. Care that has to be coordinated among specialties, doctors, physicians, other clinicians, and integrated. High quality information and education for the patient and the family. The education piece, very importantly, delivered to the patient in terms that patient can understand. There's a focus on physical comfort and pain management, emotional support, involvement of family members and friends as appropriate, not just directed at the patient. Especially in pediatrics, you'll hear the term family-centered care, and that is the equivalent in pediatrics to patient-centered care. And then importantly, continuity across transitions of care from the hospital to home, et cetera, and then access to care for all patients, access to care no matter what the demographics. So as a form of practice, patient-centered care focuses the medical attention on the patient's need, not the clinicians. A lot of healthcare has been driven by clinicians' needs. You go to Midas, you get a muffler. You go to a doctor who does X, you get X. So what we're trying to do is focus away from what the clinician does and focus on the patient. It focuses on individual goals. We don't all have the same health goals. And in order to practice patient-centered care, we have to address with the patient what are your values and what are your goals. This is a really important slide, and I'll give it to you in paper if you want to look at it later. It's from the New England Journal in 2012, and it compares traditional disease-specific outcomes and goal-oriented outcomes. So let's look at them in detail. So survival is an outcome. Everybody from a company in this room is interested in survival, whatever your drug or device is, right? Survival. That's the be all and end all, but it's not. So that's for cancer, heart disease. That's a disease specific. It is not a goal-oriented outcome for every patient. It might be, but it might not be as well. What about biomarkers? Very importantly, biomarkers used as a surrogate endpoint sometimes, not even a goal-oriented outcome ever. What is your hemoglobin A1C? That may be a goal for a patient. It's not really actually an endpoint for a person. Signs and symptoms. We track signs and symptoms, my specialty, heart failure, transplant, so we're very interested in breathlessness and edema, etc. But what the goal-oriented outcome is not demonstrating alleviation of that from the clinician's perspective, it's from the patient's perspective. And really importantly, functional status. We love to show functional status changes, especially in trials, as surrogate outcomes. For patients, I might identify a patient of mine who has New York Heart Association functional class 3 symptoms of heart failure, but what that patient's outcome as a goal-oriented outcome would be to be able to walk to the mailbox without having to stop. So we kind of have to rotate our goals. When we think about patient-centered care, we're really in that goal-oriented outcomes, not always the traditional outcomes, although survival is important to many of us. John already showed the Institute of Medicine core principles. Among them, most importantly, is patient-centered care, among those other attributes. And the Institute of Medicine defines patient-centered care as healthcare that establishes a partnership among practitioners, patients, and their families to ensure that decisions respect patients' wants, needs, and preferences, and that patients have education and support that they need to make decisions and participate in their own care. The Commonwealth Fund has identified 7 attributes of patient-centered care, and they're familiar to you now from what I've already said. Access, patient engagement. Patients aren't always used to being engaged in this process. I can tell you in my practice, I've been trying some of this patient-centered care. It's a little rough sometimes. Sometimes they say, "What do you want me to do?" Clinical information systems so that we can exchange information with other clinicians. Care coordination across the continuum so that all clinicians involved in the patient's care are communicating. Integrated and comprehensive team care. This is not just about doctors and patients, it is about the team. Routine patient feedback to doctors. A little bit of a new concept, but patient feedback is important. And then publicly available information is one of the attributes as well. So the elements of patient-centered care involve communication, health literacy that is addressed to that individual patient, education that comes from the clinician to the patient, shared decision making. I'm going to talk to you a little bit more about that in a couple of slides. Collaborative care planning and goal setting, and patient empowerment and self-management. So why do we want to do this? What's the big deal? Patient-centered care has already been demonstrated to improve disease-related outcomes and quality of life. It has been demonstrated to increase patient adherence to meds and improve chronic disease control. It clearly addresses racial, ethnic, and socioeconomic disparities in care and outcomes, and it reduces the use of diagnostic testing in some procedures. Most of the literature on patient-centered care comes from the primary care literature. We don't have a lot in specialty care yet. That's why we're involved. How does patient-centered care affect the practice of medicine? Consumers are clearly now in a position where they're seeking greater value from clinicians. Mechanisms for assessing patient experience are already public. You can go on the Hospital Compare website and look up how your patients think you're doing. Higher scores, we think, likely helps institutions and practices build brand identity. And importantly, we're all very aware that reimbursement is going to be tied to these scores and outcomes very soon. So what's the return on interest for patient-centered care? Higher employee retention in practices that do this, increased patient satisfaction. There's evidence there is a decrease in malpractice claims, reduced operating costs, and increased market share in some markets. Reimbursement and incentives will be tied to this very soon. There are current policy efforts many of you are already aware of, and they include patient-centered elements. These include value-based purchasing, the National Quality Strategy, meaningful use, a patient-centered medical home, clearly accountable care organizations, and the American Recovery and Reinvestment Act. I want to turn our attention to shared decision-making because shared decision-making as one of the elements of patient-centered care is really the pinnacle of what patient-centered care is. This involves the active engagement of patients when healthcare decisions have to be made. Usually shared decision-making is best done when there are diverging paths in a treatment choice for a patient, and that could include either medication, like a medication that a patient's going to take lifelong, or an elective procedure. Shared decision-making isn't really what we do when we have, we're in a crash out here right in front of the ACC and we have to go to the hospital. We're not going to have shared decision-making with the paramedics about that. That's not where shared decision-making is. Elective procedures and medications. This is from a great paper in the New England Journal a year ago, stating that clinicians need to relinquish their role as the single paternalistic authority and train to become more effective coaches or partners of our patients, learning, in other words, to ask what matters to you as well as what is the matter. So these are the respective roles of a clinician and a patient negotiating a decision in several different decisions. So as I said, like with an automobile accident, similarly, surgery for a ruptured appendix, that's pretty clinician-driven. The recommendations given, the patient usually accedes to that. Cosmetic surgery, entirely patient-driven. Clinician input, but patient-driven. With medications, dual antiplatelets after a drug-eluting stent, very clinician-driven, although with patient input. Statins now versus should we give a trial of 3 months of diet is a more patient-driven. So not all decisions should be in this balanced shared decision. So what is this? What is shared decision-making? This is a process by which a clinician communicates to the patient personalized information about the options, what the outcomes are and what the probabilities are and what scientific uncertainties there are related to that patient, not the guidelines, not just what our guidelines tell us to do for every patient, but how those guidelines apply to you, the person sitting in front of me. It's been widely advocated as an effective means of reaching agreement on a strategy for treatment. In the course of shared decision-making, patients need to be supported and encouraged to participate. My comment about what patients do, patients sometimes have kind of a rough go with this. They're not used to participating to the level we're asking them to in shared decision-making, and they get a little confused sometime. And I'm going to show you how we can better facilitate that. They have to be informed with accurate and unbiased information. Unbiased. What that means is the clinician talking to the patient about the decision cannot be the only source of information, because we all bring bias, just even in the way we present information. I like to tell a story about one of the novel anticoagulants. Two of my partners, both electrophysiologists, on a panel I was chairing, one of them said, "Every patient I've ever talked to about X is on it." And the other one said, "None of my patients whom I've talked to are on that drug." Where's the shared decision-making? Obviously, both doctors think they're providing data from recent trials and guidelines to their patients, but the data is so biased because we all bring to our patient encounter some of our own bias. So their goals and concerns have to be honored. A fully informed patient actually understands that there's not one right choice, that I need to make the right choice for myself. They need to understand the options, understand risks and benefits. They have to understand the outcome of choosing one intervention versus the other. Importantly, understand where there's no evidence. If we're trying to make a decision where we don't have randomized trials, we need to consider that. And then understand the importance of their participation. In order to do shared decision-making that is unbiased, we need decision aids, which are tools for the patient to use, maybe in the presence of the clinician, maybe alone. And these decision aids need to, firstly, inform the patient that there's a decision to be made. But those of you who have practiced medicine know sometimes people don't even understand, oh, I have to, we're going to decide this today. There have to be natural frequencies. Probabilities have to be presented to the patient in pictographs or information that they can understand. Patient testimonials are important. People who have the disease have faced that decision. Real people, not actors. And you have to balance the number of patients describing the situation with the number of options. And then the interview material is very crucial. Some of the decision aid issues can be that one option looks like it has more advantages, one option takes more time to explain, one option's more familiar with the patient. That's very common. People are they read the newspaper, people are much more familiar with option A versus option B, and a good decision aid will help avoid that. Obtaining the patient interview information is difficult sometimes, and sometimes patients are a little bit skeptical. If you had to make a decision today on whether or not you wanted to have surgery on a herniated disc, you could go online and use this decision aid. I like to take it away from cardiovascular medicine. So here's what it helps you do. Get the facts, so there's all the information about what a herniated disc is and what it might do to you. Compare your options. Not having surgery, medical therapy versus surgery. Number 3 is your feelings. How do I feel about this? I'm the type of person, it'll ask you questions like, I'm the type of person who just can't get over things unless I'm going to get it taken care of. So that might say, well, this may nag on your head and you may need to have surgery for that reason. Then there's your decision, and then you have to go back and rethink your decision. Your summary, then you're ready to talk to your surgeon and say, okay, here's where I am. Okay, so that's done independent from the surgeon though. So a recent Cochrane review on using decision aids versus usual care has shown a decrease in decisional conflict for patients, reduces the passive nature of decision-making on patients. It has positive impacts on communication and satisfaction, and it's reduced the choice of elective surgery, PSA screening, and menopausal hormones. So with information, people make different choices. Again, there's other information recently that patients clearly choose different treatments after they become more informed. In a recent study, you may all be aware of this, of elective PCI for stable coronary disease, nearly 90% of patients believed that a PCI would reduce their risk of heart attack despite definitive evidence to the contrary. Frighteningly, some of the doctors surveyed thought that too, including interventional cardiologists. However, once patients are more informed, they change decisions. Hysterectomy, this was prostate disease, 40% fewer requested surgery after understanding the decision. A British trial showed a decrease in surgery for abnormal menopausal bleeding with shared decision making, and a decision aid for coronary disease in Toronto showed a decrease in surgical rate for patients with stable angina when they understood the difference between surgical intervention versus medical therapy. And the last thing I want to end with is really, this was a call to arms on the part of Emily Lee and Zeke Emanuel in the New England Journal last January, which I thought was fabulous, and I don't know if it was listened to by the United States government or not, but the ACA does aim to facilitate shared decision-making. It's in the ACA if you've read the whole thing, but nothing's happened yet. So 2+ years now in, and they stated that they believe that the Centers for Medicare and Medicaid should begin certifying and implementing patient decision aids, aiming to achieve goals that include shared decision-making, improving the quality of medical decisions, and reducing costs. And they were very bold in their statement that they thought that the most critical to begin with were the 20 most frequently performed procedures to actually require that clinicians use decision aids. And they even outlined an approach to this. CMS could certify the existing decisional aids, require their use. Reimbursement could be tied to it. In fact, eventually we could be penalized for not using decision aids. The documented aids could be used as a quality metric for patient-centered medical homes, accountable care organizations, et cetera, et cetera. And then even if they pulled in PCORI, saying the Patient-Centered Outcomes Institute could be incorporated to certify the aids and used to provide feedback to the physicians and other clinicians. And I'm going to end with that. I'd be happy to take questions now, Henry, or, yeah, and, or talk further about what the college is doing currently, or we'll wait till later on that.
Let's open the floor. Comments, questions, your own experiences. Anybody, please. That's a good reminder. We went through it before, but yeah, press that little button on your microphone. Little red light comes on. Yes, Lucinda.
I just ask you, based on your study, to share with us what you think the state of the art is in assessing health literacy in direct patient
Yeah.
care.
You know what? I'm going to kick that to Ms. Hughes down here, who is an expert in health literacy, and she's on our committee and is much more expert at health literacy than I.
So if you've seen some of the really great materials that come out of the American Medical Association, you see this very sincere person saying to the patient, how happy are you with how you read? How far did you go in school? And I think in a perfect world, we would maybe interview our patients like that, and maybe in settings like cardiac rehab, when you have a long association with the patient that grows over time, or maybe in diabetes education, that's practical. But I think in our typical medical encounters, time is not on our side to be able to do that type of in-depth assessment of patients' abilities to read and understand. And so the organization that I work for and how we put together our patient education materials is that everything should be in plain language for everybody, and that we should really operate with the idea of universal precautions. And so we assume that everyone may read only at the 7th or 8th grade level, and most people like to understand information about their health verbally at the 5th or 6th grade level. And I think increasingly we're seeing that even the most well-educated, in fact, all of us, when we're patients, would rather hear something in a very simple way. What's my problem? What do I need to do about it? And why do I need to do that? So really testing people in their literacy levels, it may be done in some settings, but for the most part, I think we need to develop a common plain language approach.
And another thing, it's not just literacy, it's understanding. I was reading an article yesterday, and a little vignette was a physician going with a family member to a retinal specialist who, after hearing about the problem and the solution, said, the physician family member, could you repeat that? I'm not familiar with the terms of your specialty. So we all have a certain degree of literacy in some ways, and then, you know, you can have something else wrong with you that you've never even heard of. And it's a lot to, so I think there's literacy and understanding.
This is not new. Firstly, educated people are not always health literate, as you pointed out. You can be very educated, but in terms of health. The other thing is, people, when they come out of a physician's office, educated or not, you ask them what they remembered from that encounter. It's minimal. It's absolutely minimal. And this problem goes back. Cicero, the Roman philosopher, said, if you wish to persuade me, you have to think my thoughts, feel my feelings, and speak my words. And that goes back, a few years before your and my time, John. So this whole thing, and there's a nurse advocate you may know, Sally Oken, who has said medical terminology, it's too jargonized, we use acronyms and so on. And the question is, how do we humanize the way we talk to patients? I don't think we as a profession have solved that. I know in pharmaceutical industry, when you do consumer stuff, it has to be the Fry test, it has to be a certain number of syllables, and it has to be down at a certain reading level. But even then, is a real problem. I don't know how some of you are resolving that in what you do. I'd love to hear your experiences. Some of the pharma people want to comment on how you manage consumer communications. Nobody wants to divulge. All right. Yes,
I have a related question. Does this construct, is it the same for all populations, or is it adapted at all for subpopulations like women or African Americans? Or is there- or
No,
is it
well,
definitely
no,
the
because
same?
it's patient-centered. It's the individual patient, so that whether, whether sex or ethnicity is involved, it's that specific patient.
yes, Dr. Edelberg.
So how is the college going to lead this, developing the decision-making, aids for their members and more importantly for their patients?
You're a plant, because I want to talk about what we're doing, yeah. We have embarked on a pilot, two different pilots. We are in the Championing Care, which is the aortic stenosis education, TAVR related quality initiative. We'll have a shared decision aid involved in that, so that'll be for the first time. The other thing is, as part of our patient-centered care committee, we have a subcommittee working on shared decision-making, and we will very soon roll out our first pilot of shared decision-making, partnered with the Foundation for Informed Decisions. I'm saying that wrong, Catherine, what is it now? They switched their name. We're partnered with them, they're the experts, and the first decision aid will involve the decision for anticoagulation and atrial fibrillation. But watch this space too, because we think we're going to move quickly into procedurally based decisions, because that's much of what we do in our specialty.
Yes, Lee.
I guess just,
Oh, I'm sorry. I was pointing to Lee, who's right behind you, Greg.
Okay, thank you very much, everybody, so far for your wonderful presentations. My question is, so there was a quote that was shown from Peter Drucker about, about measurement, and I serve on the, as many representatives in this room as well, I serve on a group called the Pharmacy Quality Alliance, and we are developing medication-related quality measures. Some of these related to medication adherence are being incorporated into the Medicare Part D requirements for quality. But my question goes to, you mentioned an article that when we take it to the patient level, what's important to them is, in many cases, the functional outcome. And so I'm really, I mentioned the Drucker quote because we are all, in our eagerness to wear our quality hats, to sometimes start with the measures of what's easiest to measure, where the data are.
Right.
So if you could just talk for another minute about the extent to which these functional relationships are being elicited from the patients, and how you see that going in terms of the formal quality measurement status. Or we could come back to that later in the day. Thank you.
No, I think that's a great question. And I think that although I did draw out the parallel between the disease-specific and the more patient-oriented goals, they're not exclusive. So, for example, hemoglobin A1C can be a patient goal if the patient is fully understanding the fact that if we provide information that the literature suggests that with this, achieving this goal gets you X. As long as we don't use, in the heart failure world, somewhat sadly, we have sometimes driven some have driven their patients to wanting to have a BNP drawn every week to see how they're doing. And for those of you in that field, that doesn't really have anything to do with how that patient's doing. So I think that eliciting the goals is the big issue, and we believe that with shared decision-making, those goals become part of the common parlance in the exam room, which we've started, just in my practice, we've started doing 6-minute walk, so we can talk about the fact that we're trying to improve that as a measure, and also the Minnesota Living with Heart Failure, so we have patients in touch with, it's how I am and how I'm doing that she's interested in. So I think it's a long road, but I think shared decision-making will pull that out.
Greg, you.
I continue to practice medicine like yourself, and so one of the tensions that I feel that we face is this reward system in general for physicians has been right that we get paid for what we do, not so much for what we think. Because the thinking and the communication takes time. So I'm wondering, given your perspective and how important patient-centered outcomes are, which I totally agree with, how do you deal with that in your own practice when there is a reimbursement barrier? And/or maybe you see that as one of the key linchpins to making this happen, to pay practitioners for taking time for decision aids and so on. How do you deal with it?
I'm not using decision aids myself yet because there aren't any for the decisions for example, I speak to a patient every 2 to 3 days about the primary prevention defibrillator decision. And I give what I call my spiel. And I want to stop giving my spiel because I realize after learning all that I've learned since that jog with Fred Beauvais, that my bias is right there in that room too. So I don't have, formal shared decision-making, and my answer is I try to do it the best I can and keep on time, but it's still an E&M-based world, and until some of the measures recommended by Zeke Emanuel, I don't think, until we get paid for shared decision-making, no one's going to do it. I truly believe that. And we also think at the college, when we move into the procedurally based shared decision-making, we know that it will decrease the number of procedures done, just as it has in elective surgery. And we know that we're preparing for population health, not reimbursement. You do a procedure and you get paid. So we are positioning ourselves for the future rather than for the current state.
Yes.
And to follow up that question, it's actually what I was thinking. When you go through this,
Can you speak into the mic better?
when you go through this, this presentation, very interesting. I think that everyone in this room has a shared goal in getting to that process around patient-centered care and shared decision-making. To me, that missing component is the health systems, the insurers. So to take it a step further, my ignorance around it, does the college have involvement with the insurance companies to help drive this agenda with the health systems? Has there been any level of engagement, looking at ECC, obviously from having a very prominent position especially in the cardiovascular world, has there been engagement with the insurance companies and the health systems around this?
Not the health systems yet, but we've begun by engaging with the payers, because they're the ones who are going to grab it first and say, yeah, we realize that this is going to, and the biggest barrier is not so much that they're interested, but how do we measure it and how do we prove that it happened? We need to have, and so we're hopeful, we'll tell you more about CardioSmart later on in the day, but we're actually hopeful that that portal may help the clinician and the patient be able to prove patient number 1, 2, 3, 4, 5 went in, did the shared decision aid before this decision was made. The other barrier, though, I will say is I have a big practice. I'm telling you what, the patient barrier is huge. They just look at you sometimes and like, what do you want? Here, which would, and then the question, well, if it was your mother, what would you do? And so I think it's all of our jobs to help engage the public in the fact that it's really, you should question and you should decide. And patients always come in with literature from the internet and they apologize. And I say, don't apologize. That's fine. Some of it, we may discount this thing and that thing, but so I think until the general public understands you're going to be responsible for, and maybe their insurance company to say, guess what? You're not going to have surgery until you do something like this. That's when it'll take hold.
Yes. Barbara.
So have there been any studies to indicate whether shared decision-making has as great an impact or value when there's not a procedure but a lifestyle adaptation that's required? So as you look at things like heart failure, hypertension, this is not an either or, you will have this procedure or you won't. It's more of a lifestyle adjustment.
You mean if there's more uptake of the lifestyle change?
Yes.
Not to my knowledge, not that I've read, unless others know.
A lifestyle change, no, and everybody comes back to diabetes. Somehow A1C control does have to do with patients deciding to do, it may be medication or lifestyle change. That's the one area I know there's some data, but there's not a lot. The other thing, this discussion is bearing on something that I hope we'll raise later about paying for value. That's what insurers want to do. That's what everybody says. We want to pay for value. And the question is, what is value?
Right.
How does one measure it? Everybody here may have a different view of what value is. And it's a question I hope we'll come back to later, maybe during the panel and so on. Any other questions? Yes, sir.
Just one comment to the last question. You know, if you look at patient activation measures and you follow those, you can definitely track a reduction in costs, and you can track an improvement in patient outcomes in certain studies. So I think there is a measurable way that can prove that, and that's really, the patient activation would really be a part of the centered care approach and more of a metric of that. So I think there is a connection.
And just to piggyback that, again, another term I think is patient self-management, and I think the literature is growing on that approach to engaging patients in self-management.
Right. Okay. Thank you. Oh, yes. Okay, I'm sorry, Henry. Don't
Thanks.
go.
Just
where's-
a couple quick points, food for thought per se. So this is all great. So has the college had any conversations about, taking this to a level of curriculum development within academic medical centers, medical schools, et cetera, and making it a part of the curriculum? So that's one thing I wanted to post. And then secondly, there's societies out there like the Society for Participatory Medicine they're embarking on a mission of making the experience for the patient more participatory for not only them, their caregiver, et cetera, but trying to bring everybody together, the healthcare professional, payers, et cetera. So with that in mind, the college might want to think as you go down this road is maybe having some sort of something like a pledge that your members take that they pledge that they will engage in this type of patient-centered approach, and then also empowering the patient to nominate their doctor. That, hey, my doctor's doing this, and I want your organization to know, I want my friends to know, so empowering them to do it and connecting that with social media, et cetera. So just a couple thoughts.
Dr. Harold.
Well, I made reference earlier to the American Board of Internal Medicine Foundation, which is really almost like a policy think tank, groups of individuals that we just actually convened in Vancouver just a couple of weeks ago. And at that meeting, all the people you're alluding to, including Zeke Emanuel was there, the head of the AAMC, the head of the residency review group, and so on. And one of the focus points of discussion was how do we change the paradigm of medical education? A lot of these issues are indeed paradigm shifts, not only in medical education, but how physicians interact with patients. So again, this is a shared vision, and it's a shared collaboration and a shared communication. But you're sort of moving the bar, and to move the bar is going to require a lot of different groups to come together. And I think the more types of these type of meetings and collaborations and discussions, where even the vocabulary gets on the table, because for many individuals, they don't really know what it means or how it translates into direct patient care. But as Minnow said, it's one patient at a time. And, you can make a difference, and, we try to take cost out of the discussion. It's more about outcomes and what's going to make a difference in terms of impact. So it is a paradigm shift, and we are focusing on working with these other groups. And from the college's perspective, 6 of us were in attendance at that meeting, including Shal, including most of the presidential team, and we were meeting with Zeke Emanuel. We were meeting with all these collaborators, the director of MedPAC, and so on. So this is a hot topic from the government's point of view, and I think at the end of the day, it's the right thing to do.
There's one program you may not be aware of at Northwestern, where they have actors portraying patients in uncomfortable situations. And medical students go in, or interns and residents, and interact with them. And then, it's videoed, or there's a mentor who then criticizes. And the students involved feel it's enormously helpful to learn to a patient who may be dying of cancer. For a young doctor particularly who hasn't dealt with that, that's very difficult. And so even in academia, it's beginning the different pilots being tried to help people get more patient-focused. We're ready to move on. There'll be time for questions after. Dr. Walls, thank you so very much.